Hello, my name is Humberto Perez, and today my group and I are going to be presenting on the Ebola virus and its treatments. So, the material that will be covered in this presentation will be the following. I will be covering the introduction of the Ebola virus and why treatment is necessary. Kenny will be covering the description of how Ebola treatment works. Sonnyi will be discussing the diagnostic techniques for the Ebola virus. Sebastian will be discussing the treatment methods for Ebola virus, and finally, Marvens will be concluding this presentation. What is Ebola virus? Ebola virus was a virus first seen in Africa that was said to be transmitted from an infected animal to a human being. Ebola virus recently had an endemic outbreak in 2014 in Western Africa that caused quite a stir in the world. Basically, Ebola virus is a severe hemorrhagic fever, meaning that the patient first presents with a fever, which later progresses to a multi-organ failure and severe bleeding. This severe bleeding is due to the infection of the endothelial cells, which interrupts the proper production of adhesion proteins and cytolysis of cells, causing this vascular leakage. Ebola virus is classified as a filovirus. A filovirus is an RNA-enveloped virus. Ebola virus is transmitted through contact with an infected animal or an infected human being through contact with blood or any secretions from that person. The medical workers need to take stage 4 precautions when treating patients with Ebola virus. Ebola virus is highly contagious, and of course, it is highly fatal in anyone that comes in contact with the virus and doesn't receive treatment in time. Why do we need a treatment for Ebola virus? Ebola virus is highly contagious. It is required to have stage 4 isolation procedures when a patient is said to have Ebola virus. All animals infected with Ebola virus must also be sacrificed. So it is important to find a treatment for this virus, especially once a patient shows clinical signs of the virus, they only have a 10% chance of survival. So it is important to find treatments that can increase that chance of survival once patients show clinical signs of it. Of course, when treated early on, the patient has a higher chance of survival. In addition, a treatment can prevent these mass outbreaks that tend to happen in Western Africa and later from traveling to different countries can affect many different regions.
Hello, my name is Kenny Tran, and today I'm going to be talking about how the VSV Ebola vaccine works. So normally, the Ebola virus will attack a human cell by attaching to the anchor protein on the surface, also known as GP. Once it enters, it will produce new viruses and GP proteins, which are then released into the blood. So the infected people will need a way to produce antibodies against this GP protein that's in the blood. And the VSV Ebola vaccine will allow for this. It does this by carrying the GP protein on a non-life-threatening virus. The VSV Ebola vaccine uses the vesicular stomatitis virus, which can stimulate the immune system without any major effects. The mechanism behind it is the modification of this VSV virus. This virus was modified to present the Ebola virus surface protein. The presence of these proteins in fury triggers an immune response, generating the antibodies to the Ebola virus vaccine. The use of an RNA virus means that human DNA cannot be compromised, since RNA viruses cannot insert into DNA viruses. And because of this, VSV viruses will not usually infect humans. Immunity against VSV is also low, which makes it effective for use in vaccination, since most people will succumb to it. After vaccination, we will see a large stimulation of antibodies. These antibodies will then bind to the virus particles and neutralize the Ebola antigen, and effectively rendering the Ebola virus useless. This vaccine will not contain any other part of the Ebola, posing no risk to any actual Ebola infection.
Hello, my name is Sonnyi Kang, and I will be talking about the diagnostic technique for Ebola viruses. The main method to detect the Ebola virus is to contain the single-stranded RNA genome that encodes a viral protein. The main three are nucleoprotein, glycoprotein, and polymerase. Now, in order to contain the single-stranded RNA genome for Ebola viruses, there are four main methods. There are cell culture, serological tests to detect host antibodies against the viruses, antigen tests to detect viral proteins, and conventional and real-time RT-PCR. Cell culture is the standardized method to detect the presence of Ebola viruses. In the cell culture, scientists uses mainly viral E6 African green monkey kidney cells. After making the cell culture, it can be visualized directly by electron microscopy and indirectly by immunofluorescence microscopy. The only limitation to a cell culture is it requires a biosafety level 4, which means in order to be contained, because we do not want this disease from spreading. The next method is the serological test, and it detects the antibody detections. It detects antibodies by using a fluorescent labeled secondary antibody, and then it is visualized with immunofluorescence microscopy. In 1955, this had a main criteria role in establishing the diagnosis of Ebola viruses. However, due to its slow rate and low input, it was unsuitable in large-scale diagnosis tests when epidemics were happening at the time. However, this led to the ELISA, or the enzyme-linked immunosorbent assay. It was a faster, higher throughput system and used antigens. By the antigen test, used diagnosed Ebola virus in symptomatic patients by detecting viral antigens in serum and in ELISA. As the disease progressed in those infected, the antigen levels increased from the viruses. As the viruses increase, fatal consequences will happen for each of those infected. However, this also made it easier for us to detect the disease. So, in some cases, if we detect the antigen levels increasing, then we could stop the disease from spreading and happening. However, the only limitation to this method is that there is limited access to antibody reagents. With limited antibody reagents, we could not use the antigen test, for it requires a lot of antibody reagents. However, thanks to the CDC, it led to the conventional RT-PCR and real-time RT-PCR. Now, the CDC is the Centers for Disease Control and Prevention. Developed by them, it was first used during the 1996 outbreaks in Gabon. It amplified the nucleoprotein, glycoprotein, and the polymerase. By amplifying them, and then followed by site-based applicant detection and jet electrophoresis, it was then detect the disease, the Ebola virus can be detected through this method. It was a simple but important method at the time due to the chemical interactions of infectious viruses and the RNA extraction. This method was the first step to making the real-time RT-PCR, which we should use more nowadays. It was first used in the early 2000s in Gula, utilizing the fluorescent approach to detect Ebola viruses. It is a faster rate and a greater specificity than conventional RT-PCR. The only limitation to to this method is that there's limited data on routine PCR. This means that we have not fully tested PCR fully to the full extent on Ebola viruses, and we have limited data if this method is accurate to the point of detail. There's only been a few case studies where the real-time PCR has been very accurate. Another limitation, it requires significant laboratory infrastructure and technical expertise in molecular biology, which means we do not have that many employees working on this specific employment, which makes finding this disease using the real-time RT-PCR very challenging. However, I encourage research in the future to continue using real-time PCR because I believe this could be the method to detect Ebola viruses and we could prevent them from happening in the future.
Hello, my name is Sebastian Pinto, and I'll be covering the treatment segment of this presentation on Ebola. So unfortunately, there is currently no licensed antiviral drug by the FDA to combat Ebola, and symptoms of the disease are treated only as they appear. Supportive care, such as rehydration with oral or intravenous fluids, and treatment of specific symptoms can significantly improve the chances of survival. Further protocol for treating patients with Ebola symptoms involves placing the afflicted under quarantine for a period of 21 days. The quarantine period for infectious diseases is based on the incubation period, which is defined as the time before symptoms of an infection appear. For Ebola, the incubation period is 2 to 12 days after infection, in which it is believed patients are not contagious during this time, but can still produce small amounts of the virus. Patients under quarantine may have their symptoms treated in hospitals, in their homes, or in designated healthcare facilities. Again, there is no proven treatment available for Ebola, but progress towards a licensed vaccine has accelerated in response to the recent Ebola epidemic of 2013. During the ongoing 2019 outbreak, the first ever multi-drug randomized control trial is currently being conducted to evaluate the effectiveness and safety of drugs used in the treatment of Ebola patients. Over 160 patients have been treated with investigational therapeutics under an ethical framework called the Monitored Emergency Use of Unregistered and Investigational Interventions, or MURI for short. The MURI protocol was not designed to evaluate the drugs, but instead place a protocol for trials in which patients will be offered treatments at facilities where the trial has started. Compassionate use will continue up to the times when they join the randomization. Patients will not be treated differently from before, though they will receive treatment decided by random allocation. Data gathered from these random control trials will be useful for discovering and drawing conclusions about the safety and efficacy of the drugs. More recently, an experimental Ebola vaccine called VSV-EBOV has proven highly effective against the disease. The vaccine, as studied in a trial, involved 11,841 people. Among the 5,000 people who did receive the vaccine, no Ebola cases were recorded 10 days or more after vaccination. This drug is unique in that its use in thousands of people during the second phase of its trial showed us that it's feasible to manufacture large-scale vaccine batches for deployment in outbreak situations. It is also possible that the vaccine may be amended in the future to adapt to other emerging and re-emerging pathogens of concern, such as other filioviruses, paramyxoviruses, and arenaviruses. The VSV vaccine has already proven effective in its initial trials and only needs official licensing to be used more widespread. As of August 2019, 2 experimental treatments are working so well that they have replaced the 2 previous drugs, ZMapp and remdesivir, and will not be offered to patients in the Democratic Republic of Congo. The 2 new drugs, Regen EB3 and MAB114, are based on monoclonal antibodies that are given intravenously into the blood. Death rates have dropped to 11% in patients who receive the MAB114 drugs and just 6% in patients given the Regen EB3. By contrast, 24% of patients receiving the previous treatment, ZMapp, had died, and 33% of patients receiving remdesivir had died. With the advent of these new drugs and new treatment protocols, many scientists in the field now consider Ebola to be a curable disease.
Okay, so your prognosis with the VSV-EBOV vaccine is pretty good. You'll have rapid protection after vaccination and potential post-exposure efficacy. You'll have good antibody response, and within about a month or so, you'll have neutralizing antibodies that will be showing. There are some adverse effects have occurred around half the people given the vaccine, which were generally mild to moderate, nothing too serious, and they included headache, fatigue, muscle pain, fever, and chills. Now, your prognosis without the vaccine is, I'm sure everybody knows, is pretty bad. You'll have death within the first 2 weeks. The mortality rate is 90%. You'll have infection of the liver, destruction of the lining of blood vessels, loss of blood, which is subsequently because of the blood clotting problems that you'll have. A study was conducted including children of ages 6 and over showed that the VSV EBOV vaccine is safe and immunogenic in children. The use of the vaccine in thousands of people during clinical trials have also showed that it's possible to manufacture it on a large scale in case you need it during an outbreak or endemic or epidemic situation. The great thing about it is that there are no known deaths after the vaccine has been administered, which is normally the goal, always the goal. And patients who live throughout the second week of the infection have a higher than 75% chance of surviving, but remember the mortality rate within the first 2 weeks is 90%, so your chances of surviving through that second week isn't really that high. Women have better survival rate than men. I'm sorry, you also build a lifelong immunity to the same strand of the virus. Children less than 5 and adults over the age of 40 years have a higher mortality rate compared to adolescents and younger adults. Now, if you, by the grace of God, have the chance of surviving, then you are more than likely to have these symptoms: arthralgia, fatigue, headache, ocular symptoms, which means that you can't go blind, auditory symptoms, meaning you can't go deaf, anemia, skin disorders, and musculoskeletal symptoms, which means that you possibly can be paralyzed.